We should just start. Yeah, sure. Yep. Welcome everybody to the Rapid Fire Medical Retina Update session number 3. I'm pleased to be here with my co-chair, Martin Brellan from Hong Kong. And let's just get the session going. I think the first presenter is Dr. Tang Xingyuan. She's not going to be able to make it like most speakers in China, but I think she sent a pre-recorded presentation. So could you play that?
Chairs and everyone, I'm very glad and honored to have this opportunity to present our work. Today I'm going to share with you a new instrument which can visualize human photoreceptor cones. We don't have any financial interest to disclosure for this project. As retinal experts, we all understand that clinical understanding of fundus diseases is accompanied by the development of ophthalmic imaging. Retinal cones are integral for high acuity and color vision, and their dysfunction can lead to significant visual impairments. Their clinical significance lies in their role in diagnosing, understanding, and treating various retinal diseases. In clinic, various examination tools such as multifocal ERG, microperimetry, full-field ERG, as well as OCT can be used to detect the morphology and the dysfunction of human retinal cones. Although we have a variety of powerful clinical diagnostic methods, real-time visualization of retinal cones have not yet been fully realized in clinical practice. Adaptive optics is a tool initially built for astronomy, finds new life, combining space debris and enable quantum encryption. It can be combined with various eye imaging techniques, including traditional cameras, OCT, and SLR, to visualize retinal photoreceptors in vivo due to its high lateral resolution in the human retina. However, the high-cost AO technology makes it still primarily used in laboratory research. Many scientists have tried their endeavor to lower costs, improve instrument stability, and enhance image quality for broader applicability. Today, I'm going to share with you a new instrument which we collaborated with the microclear instrument LTD, which improve SLO measurement method and make it clinical accessible utilizing a microclear small angle view technique. This is an SLO plus pinhole optical design and digital imaging processing technique, and it overcomes the challenges of the current commercially available AO instrument, including poor instrument stability with low cost. Compared to the traditional FLIO AO system, the new system demonstrates consistent trends in capturing the distribution and density of retinal cones. The data obtained aligns well with the established patterns and metrics provided by FLIO AO, ensuring reliable and compatible results. And this consistency validates the new system capability to accurately map and analyze cone cell distribution and density, while offering additional advantages such as improved patient adaptability, cost effectiveness, and ease of use. I'm going to show you a real case in the real world. This is a 40-year-old diabetic patient with OU severe NPDR and DENV. The baseline visual acuity of the right eye is 20/60, the left eye is 20/70. OU OCT taken before the anti-VEGF therapy, and we can see the obvious cyst in the central macula. The patient will receive the anti-VEGF therapy for both eyes. Half a year later, post the anti-VEGF therapy, we can see the cyst in the macula of both eyes and the totally resolved macula in both eyes. Interestingly, the visual acuity of the right eye increased to 20/20. The visual acuity in the left eye still remains to 20/60 and did not improve at all, although the structure of the macula looks normal in both eyes. The patients will also receive the PRP treatment for both eyes, and all your wide field finders photos were taken after PIP. To explore the reason why the visual acuity in the left eye did not improve, we performed the pinhole SLO to scan the macula. We found that the diameter of the cones in the left macula is much larger, and the mean density of the macular cones in the left eye is significantly lower than that in the right eye, indicating the cones in the left eye still did not recover, although OCT demonstrated normal as the right eye. These two images are intended to show you how to capture retinal cones. The machine is easy to use and the software is user-friendly. Finally, I just want to emphasize that we have entered the era of cellular and molecular imaging. We are looking forward to more groundbreaking advancements in new instruments for visualizing photoreceptors. I want to show you the collaborators and all the team key members. Thank you so much for your listening.
Okay, very nice presentation. Shame that she's not able to join us in person. We will move on to the second speaker, which is Salma Milisic. Dr. Milisic here?
No. Okay, looks like she wasn't able to make it.
Okay, so in that case, we will move on to Gavin's talk. The first of Gavin's talk this morning is impact of early intraretinal fluid reduction in one-year outcomes in diabetic macular edema.
Yep. Thank you for the organizing committee for allowing me to present this abstract. So today I'm going to speak about the impact of intraretinal fluid reduction on the one-year outcomes and actually two-year outcomes as well of diabetic macular edema from the Yosemite and Rhine study. These are the disclosures. So I think we know resolution of fluid is a key therapeutic goal. It's the anatomical outcome of interest. Previous studies have demonstrated that unresolved fluid early on in treatment may be associated with worse visual outcomes. You saw that in the protocol I ad hoc and post hoc analysis, for example. The objective of this particular study was to look at the changes in intraretinal fluid volume, so a little different biomarker from what has been looked at before, which was often thickness or just IRF or retinal layer thickness. And look at these changes at 1 and 3 months and see if it associates with anatomical and visual outcomes at 1 and 2 years, respectively. Just a brief review of the clinical trial. There were 3 arms, one that had faricimab fixed dosing, one aflibercept fixed dosing, and a faricimab TNE arm. Here, all analysis is done for the overall group. At the moment, there was no baseline subgroup analysis because of certain limitations in sample size, etc. So in particular, what was measured, as I mentioned, is IRF fluid volume. So there was an AI-based automated segmentation software, which was run on the whole macular cube, and that allowed us to measure the IRF volume, so not the area, but the volume, within the central 3 millimeter subfield. And our outcomes included IRF volume at 2 years, total retinal thickness at 2 years, and a change in mean best-corrected visual acuity, as well as those gaining more than 15 letters. Again, there was a subset analysis because not all patients had adequate scan quality to perform this AI analysis, but there are no major differences between the overall Yosemite and Rhine group and the subset of about 800 patients that underwent this particular analysis. So we grouped the IRF volume response into 3 groups, and this was a little bit based on what the rationale was behind the protocol I post hoc analysis. In that study, they grouped it into 2 groups, a limited and a strong reduction, that being 20%. You remember that 20% reduction of CST value. Here, they looked at less than 20% and more than 20%. But that group was so big that it was further subdivided into a 20 to 50% group, and a group had a more than 50% reduction in intraretinal fluid volume. And again, in the post hoc protocol I analysis, they did find that a strong early central subfield retina thickness response was associated with greater improvement in long-term visual acuity. These were the characteristics of the 3 groups. Most of the baseline characteristics were similar, except, of course, the anatomical measurements. And as expected, the group that had a smaller reduction tended to have a smaller baseline CST, while the other two groups had quite a similar, thicker baseline central subfield thickness value. Best corrected visual acuity was quite similar between all three groups at about 63 letters. Here we look at the greater IRF reduction at baseline or after 3 monthly injections was associated with a greater reduction of IRF at 2 years. So here we looked at the three groups at 3 months, group 1, 2, 3, how much they changed at 3 months, and these bars represent how much they changed at 2 years. As you can see, there was a very nice relationship in terms of IRF response, and the SRF relationship was not statistically significant, and that's not surprising. A lot of patients did not have significant SRF, and we know in diabetic macular edema, intraretinal fluid is the bigger concern. We also then looked at how this reduction of IRF volume after 3 months was associated with the total retinal thickness at 3 years, and again, a similar relationship was identified. We then looked at the anatomical association, the anatomical change associated with the best corrected visual acuity at 2 years. And again here, the group that had very poor or very limited reduction in IRF volume at 3 months had the least improvement in best corrected visual acuity, whereas the other two groups had a greater improvement in best corrected visual acuity. And this was also similar when you looked at the percentage of patients gaining 15 or more letters at 2 years. Lastly, we did one subgroup analysis. This was exploratory to understand, do you really need to look at a 3-injection response, or could you evolve some data just from a single injection response? And here, the outcome was an improvement at 1 year, and the groups were a little bit different. You don't expect so many patients reducing 50% IR volume after 1 injection, but there was still 400 patients, so that's slightly around 40%, a bit more than 40% of the cohort. And if you look at the best corrected visual acuity improvement at 1 year, again, there was a statistically significant difference between groups, where the groups that had a greater improvement after first injection had a greater improvement in mean best corrected visual acuity at 1 year. And when we looked at the number who gained 15 or more letters, in particular, the group 3 that had the greatest anatomical response after 1 injection did the best. So in conclusion, this study shows that IRF volume is a sensitive imaging biomarker to assess treatment response in DME. It may be useful to help us predict clinical outcomes in future. And we know that greater IRF volume reduction early on is associated with improved visual outcomes. And this was both when we looked at 1 month reduction with a 1-year visual acuity and a 3-month reduction with a 2-year visual acuity. And I think it just signifies and suggests to us that rapid fluid reduction is important for better long-term visual and anatomical outcome results. And with that, I thank you very much and open it to questions.
Great, thank you very much. Yes, question at the back. Oh, whoever's taking the microphone first, please go ahead.
Okay. What you wanted to conclude from this study?
So essentially, we wanted to see if IR volume can be a biomarker for visual outcome. And that's important for us, right? Right now, in diabetic macular edema, there are not many great biomarkers for us to predict how much vision the patient will get. We always use CST, but we know in many studies, they show the correlation between CST and visual acuity tends to be poor, a kind of coefficient index of about 0.6, which is unsatisfactory.
What I can infer from your study that you divided the patient in 3 different groups, 1 responder, 1 were not non-responder. Better to go, those respond to the treatment, go with the treatment, and those don't respond to treatment, you have to add some other treatment or go for some other diagnostic method.
Correct. So again, this was a post hoc analysis of a clinical trial. So they all received treatment according to the clinical trial. And again, that's useful because I think the take home is maybe in clinical practice that 1 month or 3 month volume reduction may be a good indicator for us to change our course of action.
Thanks, Gavin. Quick question, I don't know whether you have the answer to this, but why was it separated into groups and not done continuously? Because the groups tend to be a little bit imbalanced. If you look at
I think it's always a lot more difficult statistically, to compare continuous. You end up with a correlation coefficient, and you will end up with big error bars. It was decided that it was simpler to do it in groups. And again, it's not like we tried to invent the wheel. We looked at what they did in the protocol I post hoc to establish some of those groups. But yeah, there are limitations. And again, the problem again in trying to associate one biomarker with an outcome is you're never going to get a correlation coefficient of more than 0.8 or 0.9. Then it's difficult to come to what you're saying is we come with a predictive equation. That's difficult to do. Correct. So that's, but that's just a testament to our current treatments, and this is all arms for DME are very effective.
And Gavin, just a question about, years ago we were, talking about how the compartmentalization of the fluid on the OCT could help us determine whether it was more angiogenic or whether it was more inflammatory. And I know this debate is ongoing still, but are we any closer to resolving this in terms of knowing which patients we should be treating with steroids and which ones we should be treating with anti-VEGF?
So I think we have not come to that conclusion. I think the current flavor of the month for inflammatory, as an inflammatory biomarker, is hyperreflective foci. I think people have moved away from a fluid compartment as the best correlate for inflammation. But I think it's likely it's going to be, and the problem is diabetic macular edema is multifactorial. So it's never gonna be a 1 or 0, I feel. No, so exactly. That's the challenge.
Good. Any other questions on this talk? No, in which case, Gavin, do you want to carry on the theme of diabetic macular edema?
So I'll go on to the next talk. So the second paper that I'm presenting is greater reduction in heart exudates with faricimab versus aflibercept in patients with diabetic macular edema from the Yosemite and Rhine clinical trials. These are the disclosures. So I think we all know heart exudates are an important biomarker of disease in diabetic macular edema. They are the lipoproteinaceous aggregates that deposit primarily in the outer plexiform layer. And it used to be one of the diagnostic features of diabetic macular edema before we had the advent of OCT. And we know the problems when they are deposited in the foveal region and they're very chronic. They can result in irreversible vision loss and a lot of loss of the outer and middle retinal layers. It may also represent a potential biomarker of disease severity and treatment response. And we know that both intravitreal anti-VEGF and anti-inflammatory treatments can reduce heart exudates. There is a previous suggestion, maybe similar to what Martin was mentioning, that people previously believed that steroids may be more efficacious for patients with a lot of heart exudates, although that remains to be proven in a well-designed randomized clinical trial. But here we do have a bispecific antibody that blocks both angiopoietin-2 and VEGF-A, and it has been shown to have some anti-inflammatory potential in vivo models. So the increase in heart exudate formation is often associated with progression of retinopathy, increasing risk of visual impairment, fibrosis, and atrophy. So what we wanted to do here is just to look at whether dual inhibition of faricimab did result in greater reduction in heart exudates than the standard of care arm of VEGF inhibition alone with aflibercept in this particular randomized clinical trial. Again, it's a post hoc analysis, and we assess heart exudates in a few ways. Firstly, they were assessed on color fundus photography by a Mass Reading Center, Wisconsin Reading Center, looking at a quantitative yes, no, or questionable of the presence of heart exudates in the 6 mm ETDRS grid. And this was performed at 3 time points, 16 weeks, 52 weeks, and 96 weeks towards the end of the study. Okay, and what did we find looking at a qualitative yes, no, maybe for patients with heart exudates was that fewer patients with heart exudates were present at both the 52 and 96 week time point when you look at the faricimab arm versus the aflibercept arms. As you can see here, the percentage difference was modest, but definitely statistically significant, between 7.5 to 10%. Next, again, there was an AI software that was available to do segmentation and measurements. Here, we volumetrically measured the heart exudates, not the intraretinal fluid, based on this deep learning algorithm. And the heart exudates were defined by a few things. Firstly, the signal brightness and intensity compared to the RPE. And secondly, the size, there was a minimum size requirement of more than 50 microns in order for us not to mistake hyperreflective foci, which are believed to be inflammatory cells, with these hard exudates. And this volume was then measured. These two charts look at the volume and count of these hard exudates with time. And as you can see, kind of something we expect clinically. When you first start to dry the retina, you may get a slight increase in the hard exudates, and then it starts to decrease over time. And in both these charts, you can see there is a quantitative greater reduction in both hard exudates volume and count in the central 1 millimeter field when you looked at the faricimab versus the aflibercept arms. And this was consistently also found in the 3 millimeter arms, so outside of the central subfield zone. And these are some examples of the cases where there was a definitive reduction in the hard exudates. As you can see here, significant amount of intraretinal fluid. There are hard exudates both identified in the OCT and can be clearly seen on the color fundus photograph. At 96 weeks, you have a nice dry retina and reduction of the hard exudates. And if you look at this chart, this looks at how the hard exudates decreased over time in terms of hard exudate volume, and it kind of petered off and reached its bottom level at about 44 weeks. A second case in a treat and extend arm of faricimab. This case had a lot of decercinate hard exudates, and again at 96 weeks it was a dry retina with a significant reduction in the hard exudates, visible appearance, counts, as well as volume. So faricimab results in a greater reduction in retinal hard exudates versus aflibercept in patients with diabetic macular edema, and this was confirmed both on the fundus examination as well as the OCT volumetric and count examination at 2 years. And this finding suggests the potential for improved disease control with dual inhibition, and maybe if hard exudates are related to inflammation, it may suggest an improved anti-inflammatory effect with faricimab in DME. Thank you very much.
Great. Thanks for another very nice talk. Yes, do we have a question?
Yeah. Hi, Dr. Gibbet. Very nice talk. Just, I'm not comparing with this, but I just wanted to ask you, in real world scenario, what would be your choice? Of course, these were the a little bit of small hard exudates, but when we have over the posterior pole, very large hard exudates, the hyperreflective foci, they have done a grading. I don't know how to grade it in a busy clinical practice, keeping 1, 2, 3, 4, 5. But still, in most of these where the OCT biomarkers show that there is a lot more worse conditions, is there any time you would consider using the steroid implants in these cases as compared to the anti-VEGFs?
I will be honest, in this day, now with the newer drugs available, I very rarely use a steroid as a first line, unless it is a patient which, for example, is pseudophakic and is really resistant to having that 3 to 4 monthly loading injections. Then I may consider a steroid. If not, it's almost one of the newer anti-VEGF agents.
And the steroids?
So I personally have felt the benefit of the steroids in all comers tends not to be as big or impressive. I think when we used to compare Ozurdex with ranibizumab, for example, a lot of these heavily cystic lesions or those with a lot of hard exudates, I think they did better. But with these newer generation of drugs that we get, I don't think the difference is as pronounced. So I don't use steroids as much as first line. That doesn't mean it doesn't have a role as a second line, because we know some agents would.
So now the longer acting are behaving more better as compared
Yeah,
to
it
the
seems to
next
behave better
than
than first generation.
Thank you.
How does the anti-inflammatory effect work? Is it still through the Tie2 receptor, and which inflammatory cytokines is it that it's reducing?
I think it changes the action of the macrophages, from what I understand. And we know macrophages are involved in hard exudate turnover. I'm not quite clear which cytokines are affected, but yes, it does work through the Tie2 inhibitor as well. As you know, that has a lot of downstream effects, unlike VEGF, which is a little bit more, or very much more specific.
And how closely can we associate the reduction of hard exudates with an anti-inflammatory effect? Because, you know, we even see patients where they're not being injected because they don't have fluid on the macula, but, you know, they suddenly get a scare, they sort out their diabetic control, and then over time their hard exudates get better just because their blood sugar control is better. So that's obviously not an inflammatory effect.
Yeah,
you know.
I don't think hard exudates are the best biomarker for inflammation, not at all. I think, as I mentioned, people think the subgroup hyperreflective foci might be better, but again, I don't think there's enough data to show that there's one biomarker to tell you all when it comes to whether inflammation or something else is involved. I think it's likely we end up at someday some form of rapid diagnostics, cytokine diagnostics.
Yeah, that's what I'm thinking.
Yeah.
Because, you know, we published in 2017 some aqueous sampling in
Yes.
and saw raised levels of Ang2. This was actually in
Yeah.
AMD patients, but it's a similar sort of concept. But have studies really been published on inflammatory cytokines and their responses from aqueous tapping, for example, in these sort of patients?
Okay, we have. I have an IIT that looks at it. We haven't published the results yet. We do see there is a difference, and the responders to anti-VEGF have less of some of the cytokines, CCL5, etc. A lot to do with macrophage action for some reason.
And in your data set, do you then have differences between, let's say, faricimab injected and aflibercept injected?
So that study was done. Most of it was collected pre-faricimab, so I don't have many cases of faricimab. So
'Cause
unfortunately,
that would be the definitive
correct.
evidence for that, right?
I guess it would be in part cytokines, but in part, what do we care about, right? It's the visual outcomes.
Yeah, right.
So again, it's which one gives you the best visual outcome, and maybe which pattern of pathology can still give you a good outcome, regardless of how you start.
Okay, if no further questions, then let's move on to the next speaker.
Thank you.
And we're, I think, sticking to the theme of diabetic macular edema and the angiogenic and inflammatory effects of combined treatment versus monotherapy. So is our next speaker here Dr. Malik? Yeah, great, wonderful.
Good afternoon, everyone. At the outset, I would like to thank APO AIOS for giving me this opportunity. The topic of my presentation is outcome of combination therapy of ranibizumab and triamcinolone acetonide versus ranibizumab monotherapy in treatment-naive diabetic macular edema. I don't have any conflicts of interest. Diabetic macular edema, we all know, is multifactorial with elevated levels of VEGF, interleukin-6, and various other inflammatory cytokines. Anti-VEGFs as well as steroids have shown a beneficial effect in reducing the macular edema and thus improving vision. Ranibizumab is a costly drug. Triamcinolone, on the other hand, is a very cheap drug. Addition of it to the anti-VEGF agent can increase the durability, but also has potential of various side effects. So the aim of the study was to compare the outcome of ranibizumab and triamcinolone acetonide combination therapy with the ranibizumab monotherapy in patients with diabetic macular edema in terms of visual outcome and reduction in central macular thickness. Also to evaluate the safety. Institutional Ethical Committee approval was taken, and 42 eyes with center involving edema were included in this hospital-based prospective interventional study. It was a 1-year study duration with a follow-up of 3 months. Written informed consent was taken from all the subjects. At baseline, all the patients received complete ocular examination, including best-corrected visual acuity, slit lamp evaluation, tonometry, and fundoscopy. Spectral domain OCT was done at baseline and on a monthly basis till 3 months from the first injection. And at baseline, patients were randomized to receive combination therapy, ranibizumab 0.05 ml and triamcinolone acetonide 2 mg or ranibizumab monotherapy. PRN regime was then followed for further injections. Patients with type 2 diabetes with treatment-naive center involving DME with a central macular thickness of 300 microns were included. Patients who had undergone vitrectomy, previous injections, retinal laser photocoagulation, patients with tractional macular edema secondary to any other pathology were excluded from the study. Also, patients with glaucoma, significant media opacity, uncontrolled hypertension, recent CV or a coronary artery disease were excluded. Chi-square test was used for qualitative data. Independent t-test was used to identify the mean difference between two quantitative variables, and repeated measures ANOVA was used for paired quantitative data. So the results, 20 eyes received combination therapy, 22 eyes received monotherapy. Around 45% of the subjects were females, rest 55% were males. 10 of the 42 eyes were phakic, rest 32 were pseudophakic. Right eye was more frequently involved in my study. The mean age in combination therapy was 64.1 years, in monotherapy group was 62.9 years, and there was no significant difference in the age at presentation. The proportion of males and females across both the groups was nearly similar. There was no association between the laterality of the eye involved and the intervention received. The distribution of phakic and pseudophakic eyes among both the groups was nearly similar. They showed that the lens status did not influence the choice of intervention in the study. There was a very less loss to follow-up, and it was not significantly different between the two groups. The best corrected visual acuity at baseline and at all the 3 months of follow-up was not statistically significantly different between the two groups. However, from the baseline at the end of 3 months, there was a significant difference in best corrected visual acuity in both the groups over the course of time, which suggested that there was a significant visual improvement in both the combination as well as the monotherapy group. There was no significant difference in the intraocular pressure either at baseline or at any month of follow-up. Also in the combination therapy group, there was no significant change in intraocular pressure at the end of 3 months. The baseline central macular thickness in both the groups was nearly similar. There was a significant reduction in central macular thickness in both the combination therapy group and monotherapy group. Also at 3 months, there was a significant difference between the combination therapy and monotherapy group, suggesting that combination of triamcinolone acetonide with ranibizumab led to a better reduction in the central macular thickness. At the end of 3 months, a significantly higher proportion of patients in the combination therapy group, around 42.4% patients, had more than 3 lines improvement when compared to monotherapy. So 10 of the eyes were phakic, out of which 4 underwent combination therapy, and the treatment had no adverse effects like cataract progression in 3 months. None of the patients had any serious adverse events like endophthalmitis or pseudoendophthalmitis. An average of 1.1 injections were required in the combination therapy group, as against a significantly higher average of 2.1 injections in the monotherapy group. So this is one of the patients who received combination of ranibizumab and triamcinolone. And these are the 3 monthly follow-up OCTs of the patient. There was a significant reduction in central macular thickness, and the patient did not require another treatment at the end of 3 months. One of the patients in the monotherapy group who received ranibizumab, and these are the 3 monthly OCT follow-ups of the same patient. The central macular thickness did reduce. However, the patient required 2 more injections in the follow-up of 3 months. So to conclude, my study suggested that at 3 months, a significantly higher number of patients in the combination therapy had more than 3-line visual acuity gain, with a better central macular thickness reduction, with significantly lesser number of re-injections, and without any adverse events like cataract or IOP elevation. Thus, the combination therapy was efficacious and safe. It can reduce the number of re-injections, can reduce the treatment burden in terms of cost effectiveness, especially in low-income countries like India. However, the study came with limitations of a small sample size, a very short follow-up, and very few phakic patients. Thank you.
Any questions? If not, could I ask? I've
Yes.
got 2 questions. Firstly, you presented that there was no change in the mean IOP, but we know in steroid studies, it's not mean IOP that changes, it's 1 or 2 outliers. Were there any cases where a particular patient had IOP more than 25 or 30, or none?
No, none in
None
my
at all.
study. Not more than 25, 30. Yeah, there were 1 or 2 patients who had around 23,
Okay.
but yeah, it was not significant.
My second question is, we actually do know that steroids work, even from protocol I. If you remember the protocol, the most thing that stood me out for me when I first looked at protocol I is the steroid arm's anatomical response was fantastic.
Okay.
But we also know that time and time again, all these steroid-based studies, when you extend them out to 1 year, they never show a equivalent or superior visual response.
Probably because of the development of cataract.
Partly,
yeah.
but even when you look at the subgroup analysis of pseudophakic, you end up with a similar rather than a superior outcome at 1 year. So I do agree steroids are useful. I do agree that it is a potential way of reducing costs and number of injections. But it's difficult to conclude that it's superior over the longer term.
Yes, because it was a short follow-up study.
And I think sticking to the theme of the previous questions from Gavin's talks, I mean, are we any closer to then determining which patients should have combination therapy and which ones should have monotherapy based on your data?
So my personal preference, again, patients with a lot of hyperreflective foci, cystoid spaces on OCT, hard exudates, I would probably want to go ahead with either a combined therapy or sometimes even steroid at the first go.
And the choice of triamcinolone versus Ozurdex is a cost issue for your study?
So I'm working in a medical college. We don't have patients who are very high paying, so that's why we did a study.
Okay.
Otherwise, personally, I would like to go ahead with dexamethasone implant.
Okay, good. Any questions from the audience?
Okay, thank you very much
Thank
for that
you.
very nice paper. And the next speaker that we have is Dr. Zhang Wei. I suspect he did not make it from China. No, he didn't. Okay, then we'll go on to Dr. Calvin Teo, who's going to be talking about visual anatomical outcomes with aflibercept 8 milligram.
Thank you very much, organizers, for the kind invite. So today I'm going to talk about another post-hoc analysis from the PHOTON trial. So here we're looking at the essentially the baseline the baseline characteristics of the patients in the trial and their outcomes. Here are my disclosures. So quick background here again about the PHOTON trial, just to remind everybody, good visual acuity gains, as well as patients able to extend out to long intervals on 8 milligram aflibercept at week 96. And so these two post-hoc analyses I'm going to present today, one was a pre-specified analysis looking at outcomes in patients across baseline CRT, race, age, and gender, and the other was a post-hoc analysis looking at the outcomes in two essentially baseline BCVA groups, the ones with 20/50 or worse or 20/40 or better, reflecting what we saw in protocol T. Quick recap again on the study design. So 3 arms randomized at baseline and end of study at week 96. Going through quickly, baseline characteristics here of the different treatment arms. Again, you can see they were all pretty well balanced, as well as the study characteristics of the study eye. Again, pretty well balanced. So this is, again, one more time, the results, and I'd like to highlight the fact that there were less injections given in the 8 milligram Q12 and Q16 arms with the same kind of non-inferior visual acuity outcomes at the end of the trial. So let's go into the post-hoc analysis themselves. So here, looking at the visual outcomes for age, gender, and baseline CRT, and here you can see that across the age groups, there was no difference in terms of the visual acuity gains. Likewise, across different genders, there was no differences in visual acuity outcomes, and as well by race. And if you look at the CRT here, you can see that you had numerically better visual acuity improvements in those with larger CRT of more than 400, but again, no difference across the arms. So let's look at the treatment intervals at week 96, again by these baseline characteristics. Again, similar by race, so a large proportion of patients having their long intervals and very similar to all patients. And if you look here at CRT, again, very similar to what we saw, those with a larger CRT at baseline had those with lower CRT at baseline had numerically larger proportion of patients with long intervals at week 96. If we look at the distribution by baseline BCVA, so again, reflecting what we saw with protocol T, so better than 20/50, so better than 20/40 or worse than 20/50. Here are the visual acuity outcomes, so non-inferior across the groups, but you can see a larger increase in visual acuity in those with worse vision compared to those with better, not surprising there. And again, reflected here in the CRT, so better improvement in CRT with those with worse baseline BCVA. Again, if you look at the number of injections, again, reflecting the same thing, those with better disease, in number of injections was similar across both groups, in both groups of BCVA. Again here, looking at the last completed interval, you can see that a large proportion of patients with essentially better disease had longer interval extensions, again, not surprising. So really, these post-hoc analyses were not designed to evaluate differences between subgroups. There were some limitations in the subgroups in terms of ethnicity, and essentially the conclusions are that the results for photon are very generalizable across patient characteristics, and really in line with what we see with disease severity. I'm going to very quickly talk about some new data that we have on the 156-week results with photon extension. Here you can see that in this extension phase of the photon study, visual acuity was stable right through to year 3, and you can see that 88% maintained a Q12 and 83% had last assigned interval of Q12 at week 156. I draw your attention to the low number of injections given between year 2 and year 3. Likewise, CRT was stable up to year 3, and these extension studies are important in this generation of durability trials because we really want to see how these are performing over a longer period of time. Thank you very much.
Any questions for Calvin?
Just, an interesting point on your last slide. I don't know if we can bring it up again, but there's the OCT looks like it's doing quite a big sawtooth pattern.
Yeah.
Any comments on that?
Sure. If we can bring up that last slide. Yeah. I would have gone into it, but I realized I had 10 seconds left. Yeah. So if you look at essentially the bottom curve, the 2Q8 arm, so at the extension study, all patients on 2 milligram were changed to 8 milligram at week 96. So everybody got in the 2Q8 had an 8 milligram at week 96. And so what we see with that sawtooth, we see that sawtooth in the first phase of the trial, and that's something we're quite familiar with. But if you see the sawtooth at week 96 down to week 100, you see a huge dip in the CRT, and then that slowly climbs back up. And if you look at the time it takes to climb back up, actually takes longer. So the hypothesis here is that with the 8 milligram, you're getting a good response with CRT, and it takes a little longer time to get back to that that sawtooth that we see generally, showing the efficacy perhaps of the switch to 8 milligram at week 96.
I have a question. So what was interesting and in a way nice with the design of this study is they didn't do either allow with a treat and extend. They just grabbed it by the horns and went straight to 12 weeks and 16 weeks, right? So here, although you're saying the baseline characteristic shows that all arms do equally well, given that those with worse vision and worse baseline CRT ended up with a lower proportion that go to 16 weeks, would you then suggest that if you decided not to do an T&E and do an aggressive extension after loading, would that groups be better placed to go to 12 weeks first?
Yeah, potentially. I suppose it would be nice if Bayer did a subgroup comparison between the two. I think that the data here currently is still numerical, so nothing statistical yet, but I think that's a reasonable
because I
strategy.
think one of the challenge that we have now in reducing the number of injections is as if you use treat and extend, it takes much longer.
Yeah.
So it's whether this could accelerate that.
Yeah. Okay. Any other questions?
Any other questions?
Thank you.
If not, I would like to introduce my co-chair for this session, Dr. Martin Brellan, who is going to talk about early fluid reduction with the association with durability in patients with neovascular AMD treated with faricimab.
Great. Thanks, Gavin. Yes, I have I have a relevant financial disclosure, which is that I'm a consultant for Roche. So the Tenaya and Lucerne studies, we're going to change tack a little bit, and we're going to switch from DME and talk about age-related macular degeneration. The Tenaya and Lucerne studies compared faricimab with aflibercept. in a multinational, large, multi-center clinical trial. In the faricimab treatment arm, there were 4 loading doses on a monthly basis, and then between weeks 20 to 24, there was a disease activity assessment, which were based on the criteria of CST, BCVA, and new macular hemorrhages, where the patients were then further randomized into Q8, Q12, and Q16 weekly injections, up until 60 weeks, when all patients were then changed into a treat and extend regimen. And we switched then to what we call a PTI, or a patient treatment interval, which again, based on CST, BCVA, and macular hemorrhage, allowed the investigator to either extend the patient by 4 weeks up to a maximum of 16 weeks, or reduce the treatment interval down to a minimum of Q8 weeks to the study end, which was at 112 weeks. And if we looked at the 1-year data, when patients had not yet been switched to the treat and extend, about 80% of patients could be treated at Q12 or greater interval, with only about 20% of patients at Q8 weeks. And at the end of the study at year 2, there was still about 80% of patients that were at least 12 weeks or longer. But as you can see from this pie chart, a greater proportion of patients were now on Q16 weekly injections. In the first loading treatments, the first 3 injections in both treatment arms, there were monthly injections being given to the patients, both in the faricimab and the aflibercept arm. So this gives us a unique opportunity to do a direct head-to-head comparison between the two treatments. And one of the interesting findings is the greater drying effect of faricimab compared to aflibercept on the CST measurements on OCT. We can see a statistically significant reduction of CST at 4, 8, and 12 weeks in the faricimab versus the aflibercept treatment arm. And if you looked at the proportion of patients with an absence of subretinal fluid and intraretinal fluid, then that proportion was greater in the faricimab treatment arm as compared to aflibercept at the same time points. If you then looked at the pooled patients and asked the question of how many patients had an absence of intraretinal and subretinal fluid, then reaching the 75th centile was achieved faster in the faricimab versus the aflibercept treatment arm at week 8 versus week 12. And as these patients are on monthly injections, that equates to a difference of 2 injections in faricimab versus 3 injections in the aflibercept treatment arm. So we know that there is a greater drying effect of faricimab in the initial treatment phase of neovascular AMD. But does that early treatment then correlate with the extended durability that we can see of a great proportion of patients being extended out to Q12 and Q16 weeks? To answer that question, a multivariate analysis was performed with the variables of treatment interval at 20 to 24 weeks and 112 weeks, with early fluid resolution in the loading treatments from week 4 through to week 12. With the covariates, as you can see on the right, being tested in a univariate analysis to start with, and all those variables that met the inclusion criteria were then put into the final model, which was a multivariate analysis, which was backwards selected. However, none of these covariates showed any significance. However, when you look at the pooled data and you look at the proportion of patients that received a resolution of intraretinal and subretinal fluid in the early loading phase, you can see that they are twice as likely to having been extended out to the Q16 week at the initial time point of 20 to 24 weeks in the study, and 77% as likely to be extended out to the Q12 week arm at the same treatment interval. And when you then looked at the end of the study, which was at 112 weeks, then those numbers were largely matched. So those patients that had a dry retina in the early loading phase had a 76% chance of being extended out to Q16 weeks and 65% out to Q12 weeks. So from this very short talk, there are essentially 2 take-home messages. One is that there is a greater and faster resolution of fluid with faricimab versus aflibercept. And the second take-home message is that that early drying effect of faricimab is associated both in the short and in the long term with an extended durability. And with 3 seconds to spare, I thank you for your time and attention. And welcome you all to APAO 2026 next year, of course.
Any questions?
Yeah. Really nice data there. Can I ask, is there better resolution in terms of, so you had fluid resolution for the 12 weeks, is there better resolution patients that had fluid resolution at 4 weeks, 8 weeks, and can that predict a longer treatment interval?
So what you're saying is, can we assess just on one injection
Yeah,
whether,
pretty
yeah,
much, yeah.
I haven't looked at that data, yeah, so no, we'll need to look at that, yeah.
Any other questions? Did you try to look for any other metric besides durability? Any other visual
Not for
outcomes?
this,
in
not for this study.
Okay, that will also be interesting.
Mhm.
Okay, if there are no other questions,
Great, thank
then
you.
I would like to introduce the next speaker, Dr. Srinivas Yoshi, who will be speaking about treatment response and safety of faricimab in underrepresented patients with diabetic macular edema. Interesting.
Once again, good afternoon, everyone. Thank you, Gavin. Thank you, AIOS and the organizers and the APO for giving this opportunity. So I'll be presenting the paper on the treatment response and safety of faricimab in underrepresented patients with diabetic macular edema at year 1 top-line results from the phase 4 ELEVATUM study. I have no financial interest in this presentation. So ELEVATUM is a multi-country study that enrolled around 124 patients across 40 sites in the United States. Enrollment in Kenya and India have been completed. The results are yet to be published. The ELEVATUM study showed basically with the underrepresented patients with the diabetes treatment naive DME and vision loss were eligible, especially the African American, the Latino American, and the patients with type 1 or type 2 diabetes, HbA1c less than 10%, but to increase the enrollment, increased to 12%. The key ocular inclusion criteria were patients with DME of central subfield thickness is more than 325, without prior intravitreal injections or any forms of periocular steroids as well. The BCVA of 20 to 73 letters were the key inclusion criteria for the study. And if you look into the ELEVATUM as compared to the Yosemite Rhine or the Altimer, it was almost similar, but except the HbA1c criteria was extended from 10% to 12% to have a little more enrollment, and it was exclusively treatment naive study. So look into the phase 4 open label single arm multicenter study assessing the treatment response of faricimab. The primary endpoint change in the BCVA and the secondary endpoints, that is the CST and the proportion of patients with more than 2-step ETDRS DRSS improvement study. It was given monthly injections for first 6 and then every Q4 and then Q8. When you look into the Latino patients had numerically worse BCVA and CST at the baseline as compared to the African American patients. However, it was similar with the things in the Yosemite and Rhine as well. And the Latino patients tended to have more severe diabetic retinopathy at the baseline as compared to the African American patients. The robust vision gains and the improved thickness was seen with faricimab across the racial ethnic subgroups and the overall study groups. If you look into it, week 56, it was almost 14 letters, and if you look, the more improvement were seen in the Latin American people as compared to that, but it was very similar again with the Yosemite and the Rhine study groups as well. So if you look into the proportion of patients with more than 2-step diabetic retinopathy severity scale improvement was highest among the Hispanic, that is the Latin American patients at week 20 and week 56. So faricimab was well tolerated. If you look into the adverse events, 3 patients to 4 patients had, 3 patients had iritis, mild iritis, and it did well with the help of the steroids, and they were continued in the study. And the ocular adverse events basically were the cataract, the mild conjunctival hemorrhage, or the posterior vitreous detachments. But however, none of the cases had reported any vein occlusion, vascular occlusion, arterial occlusions, or any form of vasculitis. So the take-home points, if you look into this, it's a robust vision gains was seen with faricimab in the underrepresented patients with treatment-naive DME. And the CST also observed with faricimab was definitely better. And look into the worst disease baseline was more in the Latin American. Probably that was the reason that they had a better vision gains as compared to the African American patients, and the greatest improvements were seen in BCVA and CST and DR severity as well. And faricimab also was well tolerated safety profile, and it was consistent with yosemite and Rhine. So further, Elevatum is also looking or planned at the long-term extension study like the systemic disease, the aqueous humor, looking into more into the social determinants, the clinical outcomes, the enhanced understanding of severity of biomarkers using the new segmentation and the AI tools, and provide insights into the impact of Ang2 inhibition on the disease progression. So to conclude, I'd like to say that Elevatum is the first industry-sponsored trial exclusively for the underrepresented patients in the retina, and the rapid and the high treatment completion rate, almost 87%, that was the one good thing about the study, and it was the first ophthalmological clinical trial in Kenya, and increased biomarker diversity data sets and improved diversity in the speaker investigators who represent the patient population. Thank you very much for the patient listening.
Any questions?
So I'm a bit confused about the HbA1c. Why was a different HbA1c criteria chosen?
So to increase the enrollment, because not many patients were seen, especially if you take a country like India, to be more practical, we see a lot of patients with uncontrolled diabetes and less than HbA1c with treatment naive, because they usually start with the lower anti-VEGF, like ranibizumab or sometimes even IVTA. And since us being a tertiary care hospital, I see most of these patients who already take and come up. So the treatment naive becomes a real difficulty in these countries, and I feel that if you increase the HbA1c to 12, definitely you will have more lot of patients who can be enrolled. And we definitely wants to know which works the best. Let's look into the real world rather than only select group, because if I see in my own practice, I think only 30 to 40% will be in the control group. The rest majority will be in the uncontrolled group.
Because it does kind of explain why there's such a big difference in the diabetic retinopathy grading. The fact that, you're choosing more severe diabetics, basically.
Yeah. So this was basically compared between the Latino and the African American, and I looked into a little bit of the literature. Probably the Latin American patients have the higher propensity of having diabetes. Severity of the diabetes is slightly higher in them, and there are more patients are on insulin, and the male propensity is more higher as compared to the women. And probably because of the screening and the reachability to the medical facilities also could have been attributed to these cases, and that's why we see the more severity in the Latin American patients as compared to the African American patients.
So being a single-arm study, do you think the data from here would change your choice, and what would you like to see in terms of?
It's a good question, Gavin. Yes, definitely it is showing promising results. I do agree that it would have been a head-on study with the two that would have given the better results, but probably coming into the future, probably we can do that. But this was one of the first study where the representation was taken into the people who were not considered earlier in the study. So this was the first underrepresented study in the areas where there was no much treatment available for that.
Thank you. I mean, I recall when we recruited, the main reason why we rejected patients was HbA1c. Yeah,
Good.
Thank you.
Thank you, Gavin.
Okay, so I'd like to invite the next speaker, Sri Hudaya Widihasta, who will be speaking. He's got two topics. The first is the safety profile of intravitreal bevacizumab biosimilar.
Thank you, everyone. Good afternoon. First of all, I want to say thank you to APO Committee for this opportunity. Today, I will present my study on safety profile on intravitreal bevacizumab biosimilar for retinal disease, a single-center retrospective study. I have no financial disclosure in these presentations. So, as we know, that biosimilars has become increasingly significant in ophthalmology, particularly in settings where treatment costs a pose of barrier. According to WHO, biosimilar are biologic products that are highly similar to reference drugs in terms of quality, efficacy, while offering a more economically viable options. This is a bevacizumab. A bevacizumab biosimilar is notably the first Chinese antibody drug to be approved and locally produced in Southeast Asia, and it received approval from Indonesian FDA in June 2022, and it contains the same active ingredients as Bifasta. So research on biosimilars is crucial, as this product, while highly comparable to original biologic products, they are not identical. So small structural differences arising from distinct manufacturing methods might influence their clinical behavior. Therefore, studying biosimilar is necessary to confirm that biosimilars remain safe alternatives, and also we can see that they will expand in managing various retinal conditions. Our study aimed to evaluate the real-world safety profile of Befagin when administered intravitreally for various retinal conditions. So this was a retrospective chart review. We collected data from my center from January 2023 to June 2024. We assessed the ocular and systemic safety outcomes over 4 week of follow-up period. As a note, that procedure of anti-VEGF in my center were performed in operating room under topical anesthesia. So across this study period, a total of 3,134 intravitreal injections were performed on 630 eyes. And as we see here, most of the cases were AMD given to more than 43% of eyes, following by DME and BRVO. Notably, there's 7 cases of increased intraocular pressure increase reported, 5 in patients with DME and 2 in AMD. And there's no cases of ocular pain, IOI, endophthalmitis, corneal edema, retinal detachment, vitreous hemorrhage, or optic neuropathy were recorded. So importantly, there's no systemic adverse event as well. Yeah, so this support that there's a short-term safety profile. So actually, there's also other studies that have evaluated the safety profile of bevacizumab biosimilars under different brand. Even though like one of the study from Wang et al. Is reported the case of endophthalmitis, uveitis, vitreous hemorrhage, and RPE tear in 6,230 eyes that were given MVASI. And then also Agawa reported 104 eyes. There's no adverse event by given at Zyvev. And also for Stevant, there's also reported 1 case of vitreous hemorrhage in 385 eyes. So this discrepancy may be happen due to the differences in injection techniques, patient selections, and also procedural protocols. But however, in this study, the absence of serious complications across 3,000 injections in this study is reassuring the safety profile. So furthermore, the use of biosimilar could play a critical role, especially in a place where there's a limited resource settings, especially in my country, in Indonesia, because of the biosimilar have a low cost, over 25% lower than the original drugs. So to fully leverage the benefits, it is essential to integrate them into like guidelines and can be implemented in clinical practice safely. So as limitations, maybe some adverse event may be unreported since it is retrospective studies, and moreover, long-term data on safety profile also needed. But despite its limitations, this study offers preliminary insights into safety profile, intravitreal bevacizumab biosimilar retinal disease, and it can be one of the options to have affordable retinal care in a limited country like Indonesia. Thank you.
Thank you. Any questions?
Yeah, nice study. But do you find any much of cost difference in your country between the biosimilar ranibizumab as compared to the biosimilar Avastin?
Actually,
in my the biosimilar ranibizumab price have reached almost rock bottom. What the Lucentis first started it and put it at the rocket high prices. But now in the developing countries, I still see that the prices have come down. And do you still want to risk it because it's an off-label drug?
Yeah, actually, there's also a problem.
Legal and these implications on these things. I just wanted to know your.
Yeah, I agree with because nowadays biosimilar is really happening. One of the example that ranibizumab biosimilars is also can be used in my country, but unfortunately, there's also a problem in our government limited of the insurance kind of thing. So this is really limitations of the price there. So we kind of, but in my country actually we're trying so hard so we can have a better options for anti-VEGF.
I feel so happy about the biosimilars, Gavin. When I first presented in 2017 in San Francisco, in the American Society of Retina Specialists, when we presented the biosimilar ranibizumab, and all the people, especially the press, the medical press, hawked me and telling that how can you try to develop an injection of $250 when it was $1,600 or $1,700, what was the cost of it. But I think there should be some cut-off level, because I personally feel, of course, Avastin has shown to be a much effective drug. There's definitely no question about it. And Indian ROP studies have also shown that Avastin has proved more than compared to the ranibizumab in all these things. But the only thing I would like to be safe is about the implications of the legalities, since it's an off-label.
Yeah,
That's it.
thank you very much.
Thank you.
And also, I mean, like this is like one of the sample that safety profile. Actually, if I was the doctor, I will rather to give them the best possible that I can give to the patients. But it's a safety profile study. Yeah.
Okay. So one of the big cost reductions with bevacizumab was that we were compounding it ourselves. So is it the same now with this biosimilar, that you get it in a large vial and you're compounding it yourself in the operating theater, or your pharmacy is compounding it?
So actually, like if we, I don't have the data like how much is it decrease the cost, but if there's a calculations like it's almost four times lesser.
Yeah,
Than
but
Avastin. 4 times less than Avastin.
4 times lesser than Avastin. Yeah.
But this biosimilar comes in a large vial, right?
Yes.
And how many injections do you get out of one vial?
It can be given to wait, this is like more than 10. More than 10. Yeah.
Okay. It's interesting also that we were just discussing this, that it's a Chinese biosimilar, but it's not available in Hong Kong.
But there are biosimilars. There was a bevacizumab biosimilar that's going for FDA approval for eye indication, but it was not this one here. Okay, and again, I think Dr. Vida Hasta has this next talk, which is talking about microperimetry biofeedback training to reading speed with patients with AMD.
Thank you for the introductions. I know that it's kind of different with other, because before we talk about almost every drugs, but this one is a different view. I talk about the effect of microperimetric biofeedback training on reading speeds in patients with age-related macular degenerations. So, as an introduction, AMD is a leading cause of irreversible central vision loss, particularly in individuals over the age of 60. Like globally, we know that AMD affected approximately 196 million people in 2020. So one of the most disabling symptoms of AMD is the loss of foveal functions, which is significantly impairs central visions and daily tasks, most notably reading. So when the fovea is no longer functional, patients tend to develop an adaptive mechanism called preferred retinal locus, or PRL, which is a region of the retina that compensates the loss of central visions. However, this natural adaptation is often inefficient. So this is where microperimetric biofeedback training, or MBFT, comes in. So MBFT is a technique that actively trains patients to relocate fixations to a more optimal area on the retina, one that retains greater sensitivity and better stability. So our objective was to evaluate the impact of MBFT on one of the most critical aspects of visual functions, which is a reading speed. So we conducted a prospective interventional study at Cicendo Eye Hospital, Indonesia. So patients included are those who are diagnosed AMD confirmed by both fundoscopy and LCD macula who are not on active state. We make sure there's no indication for anti-VEGF therapy. We included those with best corrected visual acuity between 1/60 and 0.3 logmar, and here are the rest of inclusions and exclusions criteria. We make sure that there's other eye disease that might intervene. So the procedures that each participant completed 6 weekly sessions of MBFT lasting 10 minutes using the NIDEC MP3 microperimeter, and the training was targeted at a new trained retinal locus, or TRL, which is specifically we selected in the superior region of the macula. So reading performance was then evaluated before and after training using the Minnesota Low Vision Reading Chart. So these are our drop-up criteria for the patients who are skipping the exercise twice in a row, and also if there's a significant change in visual acuity due to the worsening of AMD. So here's the pictures of the training. Okay, So here's the result. So following the MBFT 6 times, as we can see here in the table, that patients showed a statistically significant increase in reading speed, both means and medians. And let me draw your attention to the image on the slide. So as we know that there's a clear functional shift in the fixations. On the top, you'll see the pre-training microperimetry map where the fixation relatively near to an area with lower sensitivity. And after the training, the fixations become more concentrated in the superior right retinal area, which is the R-designated TRL, which has a better stability and higher sensitivity. So this shift in the oculometer reference points enable a visual system to utilize healthier photoreceptor, improving not just reading speed, but also the fluency and comfort of visual task. So some literature also reported this similar result as well. So MBFT leads to improved fixation stability, retinal sensitivity, and overall visual performance in AMD. So reading ability is a particularly important metric, which is not only reflects central vision equality, but also it's a patient's quality of life. So our studies support that the idea that MBFT can train the brain to reinterpret visual input more effectively by shifting fixations to a more functional retinal locus. So this is MBFT is accessible, well tolerated, and can be performed in outpatient settings as a rehabilitative options for patients after getting optimal treatment for their conditions, for example, AMD. There's also some limitations because we did not include long-term follow-up, so we cannot draw conclusions about the durability of the improvements. Moreover, we also didn't directly correlate we don't have data on the quality of life directly. So hopefully future research can explore more of that. So to summarize, microperimetric biofeedback training significantly enhanced reading speed in patients with AMD by improving fixation stability and retinal sensitivity. And this technique is also simple, safe, and highly promising as a rehabilitative tool for AMD. Thank you for your attention.
Any questions? If not, I have a question.
Okay.
So this program, is it something that's provided for by the NIDEC system, or it's a separate?
Yeah, actually, this is included in
NIDEC
NIDEC system.
system.
So for
And I mean, the results look encouraging, but you know, you show averages. So for me, averages always doesn't tell the full picture. Was there a group that did better, a group that didn't do as well, and were there any anatomical characteristics that suggest?
actually, there's also data related to comparisons between those who got improvement and those who got training and who's not, but it's in another study. Yeah.
Okay.
Just report.
So I wonder the whole topic of eccentric fixation. I just tell my patients this will happen naturally over time, and your brain will naturally just choose an area of the macula that's optimized and working at its best function. So I don't really suggest to them that they need training. So your study is quite interesting from that point of view. Should I now be saying you will achieve eccentric fixation faster if we put you into a sort of training program to be able to do this? I mean, the end result, I imagine, would be the same, which is that if you leave the patient to do it naturally, or whether you train them, they're still going to use the part of the macula that's working the best, right?
Yeah, actually, there's also a study that the fixations, there's also like pervert retinal locus, which is like happens naturally to someone who has foveal dysfunctions, but it happens usually 6 months. And also, some patients will desperately want to have a better outcomes. You know, like sometimes patients come to our practice and they really want to have a better. It's not like it's not easy that okay, just let them do it. Your body will compensate it. But after the training, the patients become more eagerly to have a better function, because as we see, it's only 6 times, and every week, and the training is only 10 minutes. I think it's not something that is really hard to do for the patients. And even though after 6 times of the training, we can see that the locus is shifting, so we don't have to wait until 6 months just to have those.
Yeah, and I guess coming back to Gavin's point here is that it must be a subgroup of patients that you very carefully select that have very focal scarring from AMD, for example, because you know, a big disciform scar and this isn't going to work, right? So,
yeah, thank you.
Yep. Okay, thank you. Can I find out, did the last speaker provide a pre-recorded video? Because I understand that she was supposed to have It's not. The last talk. The last talk. Okay. Thank you. Thank you. The last talk. Oh, this one? Yeah. Is there a pre-recorded? No. Okay. Okay. Yep. If not, thank you very much. I think this was a very interesting session that gave us a big, broad outlook about the different drugs, the different subgroup analysis that's available. And I hope you enjoy all your flights back home. Thank you.